You're listening to the Physio Matters podcast in association with Choose Health, and this is session 39. Welcome back to the Physio Matters podcast. I'm Jack Chewy, and I'm rather excited to introduce, not necessarily this episode, but just generally speaking, we've got an awful lot to tell you. The Physio Matters team have put their 2017 plan together, and some of the episodes that we've got, particularly on the main feed, are well, we would say this, but they're brilliant. Management of the ankle, strength and conditioning. We're going to do an episode on analgesia and prescribing. Management of neck pain, potentially later in the year. Hopefully going to get some on martial arts, OA knee, I've already mentioned that. So just loads of good condition-based stuff, as well as some of the broader issues and principles around musculoskeletal practice. Super excited about it. We've got some great guests to bring you, as well as this year we're going to really make sure we get ourselves to events and start covering those. So make sure you keep an eye on our social media, particularly on Facebook. We'll try and use Facebook Live when we get to those events, as well as potentially starting to live stream on our YouTube channel. So all sorts of really cool stuff going on. So far this year, we've touched on two rather controversial topics: future of the NHS and manual therapy. We're delighted with how those episodes have been received, not least by the numbers. I mean, the download rates for these episodes have been incredible. And then the feedback has been wholly positive. I mean, it's sort of 90% positive on both episodes, which is just mental to cover such hot topics and get such an overwhelming response. I hope that's because we covered things thoroughly. And there's definitely criticism that can be placed at our door and others, and the guests, of course, on those episodes. But generally speaking, it's as if we're being able to carve out a balance that doesn't suit no one; it suits everyone, and people are respectful of the opposing views. We've come into angles with strength of the opposition to our views, and so generally speaking, we're really pleased with how those have gone. If you haven't already, then please do have a listen to those episodes. We touch on some controversial things, and the last episode, I've got to thank again Neil Langridge for an incredible chat around his journey around manual therapy and some real admissions from him about the evolution of his thoughts. And I think that's an important thing for me to just touch on now is we've got to be proud and give credit for when people do evolve their thinking and not attribute some of their previous ideas and views to them in the present when they might not be still attached to them. We get some people will double down around an idea, particularly when they're really invested in it. So when people do move forward, the idea of considering them sort of flip-floppers on these issues or people that are sort of slippery, that's certainly not a good approach to have. Is to call them out on that. Certainly there are people that will sort of spin a line in a direction when it suits them and then flip back over to it. But generally, being versatile in our positions on things because of, in light of new evidence or having been buying into a better argument for another direction or moderating your views and things like that, that's exactly what needs to be applauded. And Neil's a perfect example of that, and I think one of the reasons why it's an overwhelmingly positively feedbacked episode. Oh God, my grammar is atrocious, and I'm afraid you're going to be stuck with my witterings for a little longer in this episode. This session brings you a discussion around spinal surgery from a patient's point of view and the journey before, during and after an episode of care that required spinal surgery. And very, ever so strangely, that patient is me. So quite a unique angle as being someone that's in the musculoskeletal industry, working with patients of all kinds, particularly spinal patients and complex cases for triage purposes and understanding what the best course of action is. You know, I work with people like that all the time, and so for me to encounter a situation in which I needed external help, in this case surgery, to help myself, and the pros and cons that come with that, and the journey and the reasoning that I had to deal with, both in terms of emotional turmoil personally, but also the support that I sought from my friends and colleagues, and the experiences I had in the health system. It's been a really interesting journey, and I didn't necessarily think about broadcasting it until I was persuaded by my friend and colleague Paula Deacon at IPOPS, who had helped me through the process. The first person to persuade me to be assessed when I was trying to bury my head a little bit, and so she'd said that especially once, and I agreed to talk about it once I was feeling appropriately better. So I'm doing well, and so I didn't want to go too quickly and suggest it had been a success when it hadn't, so I'd postponed it a little bit. So this is a real 2016 story that we're bringing forward, but Paula had persuaded me that it was worth telling, and that it was of value to the community that we serve and the people like you guys that listen to this, to understand how to give a different perspective, a very, what we hope is a unique perspective on these sorts of issues. And so today's interview, funnily enough, is conducted by Paula with me, and so you've, like I said, you've got me to put up with for a little longer. Massively appreciate Paula's time as ever, not least for her care and compassion when dealing with probably the most awkward patient I can think of, which is me, asking a lot of my body and mind at all times, and so her patience with me has been incredible. And then for her to push me to tell the story and take some time out one evening after work to record this interview with me, and to hold me account and not go easy on me in the Physio Matters style, I think was really good, really, really helpful. So I thank you, Paula. Thank you, IPOPS. Thank you, the patience of the team that I work with there 2 days a week, and they make me feel so at home. I'm delighted to be part of that service, and also shout out as ever. You probably will start to realise why I've been such a mushy sod in the last 6 months or so, particularly with the Physio Matters team, is that you get an insight now as to why it's so important to me that I've got such a great group of people around me to bail me out of all these problems I've been having with my body and routine, shall we say. So huge thanks to them, and I don't know how many times I can say thank you in one intro, so I'll see you at the end to tell you about some really exciting stuff going on, how to enter some competitions that we've got for courses from Neil Langridge, our previous podcast guest, and from Benoit Matthews, who's kindly donated one of his space on one of his courses to Physio Matters patrons, and potentially even social media followers. So I'll let you know at the end what we've decided to do with those freebies. But without further ado, I bring you session 39, which is Paula Deacon and me.
Jack, here we are. Your turn to be the other side of the microphone. Seems a bit strange that I suppose almost 2 years ago you were interviewing me, and now I'm interviewing you.
Yeah, I think you're probably the bravest person, or the most ambitious person, because you think that you can interview me about me, and I might try and keep it to an hour. I think we're going to be here for hours.
We
so
probably
I'm
are.
concerned. So it is weird to be answering questions rather than asking them, but I think it's well worth talking about, isn't it?
Yeah, definitely. And I think, thank you. I think for your listeners on their behalf, thank you for sharing your journey with us. And I think you're going to elaborate on that in a minute, but I think it's going to give us, hopefully with the questions we've put together, an insight into what it's like to be on the other side of pain. Thanks for sharing that journey with us. No problem. So if you'd like to give us a bit of an overview then of what we're talking about.
I mean, I think I'm not good at keeping a long story short, and the listeners will know about that. But generally, I do a variety of dangerous things with my body, in and out of sport, and do a lot of adventure sport, and have had a history of back problems, but always manageable. Mainly stemming from a big crash that I was in on my mountain board, which is like a big glorified snowboard that rides across land rather than snow, which hurts more when you fall off. And I had a big crash on that when I used to race them when I was 18, just before I went to university. And so I've had back problems on and off from then, and occasional left-sided leg symptoms, but again, always manageable. And then I got back into racing a few years ago. My sister dragged me back into the sport and started racing again. Now, the reason I tell that tale is because I started to compete and do well, but I was on the cusp. I got a few podium finishes and won a couple of events, and so I was trying to challenge for the title, what was 2016 season. So I bought a new board because I was riding a bit of a museum piece, an old thing that when I used to be sponsored, I used to have this old board that was made for me. So I'd been riding that, but it was 10 years old. Bought a new board to try and see if I could compete in the 2016 season, and obviously then was trying to get used to that again. So took that into the skate park, which they're not designed for, but it's kind of a good training tool. If you can lug a heavy thing around a skate park, then it kind of gets your legs dialed in. This was in February, so pre-season. And what would normally, in a session like that, I'd usually ride for an hour and a half, and my back would get a bit tight, so I'd usually knock it on the head at that. And you typically would come off once or twice because you're not pushing your luck too much in the skate park, and it's well within my ability. But on my new board, all my timing was out, so I came down fairly hard onto my backside, and I'm strapped to this heavy lump of a thing. And I'll probably be on the video version of this that we'll put out, at least to patrons, we'll be able to show some images, probably even of the session that I'm talking about, where I landed bluntly onto my bum probably 8 to a dozen times from height, and it just kept regularly doing it. And so what would normally happen after a session would be that I'd sleep it off, and it'd be a bit stiff in the morning, stretch it off, it'd be okay. But this session was about 2.5 hours, so I'd done an extra hour and all the falling off. And then the next morning, it hadn't recovered. It was feeling sore, and so I realised something was amiss because it just didn't settle down. And this was just axial back pain at the time. I didn't have any leg symptoms, but I could tell something was amiss. And then over the next few days, I started to get this really unpleasant sensation of instability. Essentially, whenever I flexed forward, particularly, it was just really disconcerting. Still central. Starting to get a little bit of my left leg symptoms, which felt familiar from old, but just started to feel really strange. And really gingerly sitting down and things like that. Just any time that I needed to flex either the hips or the back or both, it was starting to feel weird, and that just continued to worsen. Fortunately, coming into work, that's probably when I put it under your nose and you assessed me for the first time, because you were sort of saying, look, this needs looking at. You're moving really sheepishly.
Well, I think you weren't comfortable extending. I think you were.
I don't remember it. At that point, I remember it was. Extension certainly became a problem further, but. First noticed it into flexion, but then I started to lose movements progressively, and extensions just started to be a real problem. Still no leg symptoms at that point, but I wasn't going into extension. I had this really narrow comfort zone, and it was quite strange. So because of the nature of the onset, alarm bells started to ring a little bit, and what have I done here? This wasn't responding like I'd expected to, and wasn't behaving as I thought it would. Started to influence my sleep. Certainly didn't like rolling over. Started to feel tense through my thorax, and then at that point, I think from at that point I had no sort of neuro symptoms, did I? But it seemed smart. I think that's when it was sort of felt like it was a smart move, where we were wondering if there was spondylolisthesis at that point. Yeah, I mean, it was interesting really, because I saw you 2 weeks after you'd had that heavy fall off your skateboard and that instability feeling, and I think you'd lost so much. Quarter range flexion with this quite severe instability feeling. I remember you describing that, and in your notes, that was the main thing. But you'd also been getting you'd had some abdominal pain prior the year before that hadn't been investigated, and I know that they became a bit more prominent as the weeks went on. Down to the anti-inflammatories, I think. Yeah, I'd forgotten about that. So you had all this abdominal, wasn't sure, hadn't been really investigated. This heavy fall, and it was quite unilateral, left-sided SIJ. A little bit of proximal limb pain, but nothing distal. This was just 2 weeks after that. And just your deteriorating function was the main thing. You tried modifying your activities, but it was your flexion significant. You could barely flex.
hands to mid-thigh. I mean, you just were not comfortable. And like you say, yeah, your other movements were preserved. You had this bilateral where your SSTs were down 50 degrees both sides, which you felt were normal for you anyway, didn't you?
Tight through my hamstrings typically, and I'm so lanky of leg, so I've never been particularly bendy that way. But yeah, it wasn't at that point. The interesting thing really wasn't provoking much in way of limb symptoms.
No.
But that's when we got the MRI scan about 2 weeks in, wasn't it? So it was quite an early. We organised the scan fairly early, wasn't it?
It was about a month after onset because your flexion was deteriorating significantly.
Yeah.
You'd had an awful weekend, you could barely rest. Yeah, it was all, and you were getting some posterior thigh and you were getting some calf sensations. This was 4 weeks post onset, and then your gait you were starting to have a laboured gait, antalgic gait.
Mm-hmm.
You didn't like going into hip extension, spinal extension on that unilateral side. And your flexion, and that's the second time I reviewed you, your extension had significantly reduced. Bit of a stalk test positive on the right side. Yeah, you just multidirectional dysfunction. I mean, it was all significantly reducing. And actually your slump on your left, you were starting to lose extension at 30 degrees, and the extension you were reproducing some sort of irritation, neural irritation, where previously it had been okay in your available range. So you were starting to deteriorate. You know, you weren't looking comfortable walking around the department, that's for sure.
And I know we're planning on talking about medication, so I won't talk about it too much. But at that point, just for the listeners to get some context, is that I was taking regular cocodamol. I had some Zapane from an old tooth abscess that I was taking, and I'd then at that point went to see the doctor and got some Zapane cocodamol, which is certainly helpful. I think I could sleep through on that, and it was starting to help me, and it always has been fairly good. I've been alright on cocodamol before, so that was pretty handy. And that's when we got the MRI.
Yeah, because over the course of 2 weeks, your movement had significantly reduced, multidirectional, slump had increased sensitivity, and just because of the trauma, you were sleep deprivation, higher analgesia needed. Yeah, so you got an MRI, which we got quickly through.
We organised that quickly, and. Big relief, really. I mean, and that's sometimes too much knowledge can be unhelpful. Sometimes I wasn't necessarily that worried, apart from the thought that if this was a spondylolisthesis, knowing what I like to do, and it's not just the mountain board, and I could knock that on the head, but generally speaking, I like to ride a lot of boards. I like to climb. I like to do impact sports, and so it would have been a real frustration to do that. And so, especially because that was sort of one of the primary hypotheses that we were thinking at the time. When we got the images up, and I could see straight away that I didn't have a PARS issue, and that I hadn't had a slippage, I was really relieved. But what it did show was at that point an old issue that I knew I had, which was an L5S1 left-sided. Fairly non-compressive, but a substantial old lesion there was still lingering, but a new posterior bulge on just the one up on 045. At that point, just posterior didn't really seem to favour a side, and that was new. But at that point, to be reassured on the fact that we hadn't had a spondylolisthesis, bearing in mind the only real limb symptoms I was getting were on the left side, ones that I was familiar with and stuff. So I was quite confident then. I thought this might settle down, and it really didn't, did it? Like the next few weeks, despite.
I think I've got that. You had your scan. And actually, clinically, you were doing a lot better in terms of reduced low back pain. You had increased flexibility without
loads more less back pain, yeah.
Yeah, and your instability sort of improved.
Yeah.
But you'd noticed 2 days after the scan, you lost power in the hallux on the right side.
Yeah, I can't remember if it's...
And Tibant was preserved.
I can't remember how relevant this was really, but I was in my office as the instability was decreasing. My back started moving better, and it's I'm interested. I don't know whether it was the scan had offered sufficient reassurance to get me going again. But certainly around that week, I did get a decreased sense of instability. I'm completely open to that being a decreased anxiety, but it did start to recover in that sense. But I was in my office pottering about and becoming more confident with my spinal movement again, and I flexed and twisted and got a bit of a jolt, and first time I experienced right-sided leg pain. And that evening, just this really just coldness sensation into my right big toe, to which I noticed I had flat toe, and it was absolutely like I'm staring at my toe and I couldn't make it sort of even flicker, which was concerning. But no other symptoms, and as you say, tib-amp preserved, is able to walk on my heels, and that's the sensation that's one that I will always learn from for patients as well, is that I essentially then started, and you guys, I know we had a laugh, didn't we, because I was high stepping, especially barefoot, super high step, even though I still had dorsiflexion. It wasn't a true foot drop, but your sensation of not being able to just lift your hallux at all meant that I was high stepping and overcompensating all the time. So I had this sort of pseudo foot drop then for quite a while, but only really it was flat tone for, I think, if I remember rightly, a couple of weeks. It started to return, didn't it? It started to improve, but by that point then I had no back pain and no leg pain down to the shin, and then just a searing shin pain, and this is on the right side.
When I checked your Neuro End of March, your flexion was good. You got that back actually. That had gone down, hands to tuberosities, good fluency, extension was returning. Movement wise you were good, but your neuro reduced sensation over the right hallux with loss of sharp blunt discrimination, and that was really, your slump had even improved, but motor and sensory, almost a mononeuropathy on that right side. That actually started to, it sort of fluctuated, didn't it? It'd go a little bit and then it seemed to deteriorate a little bit.
It seemed to vary. And I think what at that point though, it was so clear that extension had become a block. I could elicit, and it was a strange sensation, I could elicit my symptoms just by posteriorly tilting. So I could just tilt into neutral even, and I could bring on my shin pain in whatever position I was in, no matter what neural tension I had on. I could just tilt my pelvis and bring on those symptoms like you were pushing a switch. And
posterior tilting, weren't you? Not anterior.
Sorry, no, anterior tilting into lumbar extension, and that would bring on my symptoms. And that then was the process. I was again still recovering in a sense. Decided that I think around that time it was smart to then, especially because it was so sensitive to any neural tension. If I did, the more I did, the more I struggled at night. It seemed smart to then get onto some neuropathic medication. Didn't go for a amitriptyline as a precursor, mainly because 3 days a week I'm up at 5. I travel down here for IPOPS and also for other clinics with Choose Health, and so 3 midweek, Tuesday, Wednesday, Thursday, I'm up at 5, and so if I'd have been groggy, I wasn't cycling, so I was having to drive to the train station and stuff, and it would have really thrown me. So me and the doctor talked about it, and we went straight on to pregabalin. And I'm glad I did. Within a couple of weeks, that was really helpful, making it much more manageable, took the edge off. Still very stubborn, and I still had to not push my luck, but it certainly that kept me in work, that kept me functioning, that kept me getting at least a good few hours sleep, and being able to get back off. So that was really helpful. But even with that, I could still switch on and off my symptoms, and particularly the numbness, the weakness, though resolving, was slowly resolving. And at that point, it was really clear that I needed to find a way to phase back in my extension, because it was extension that was stopping me. Even a walk of any duration was aggravating. I'd have to sit in a real slouch, which just didn't seem smart to be doing, and so I needed to phase that back in. But no way in which I could try to break it back into extension, no matter how I tried it, and we did try a few things, and I was fairly fairly vigilant with what I was doing. You know, I knew what I should be doing. I practiced what I preached, and I've had plenty of injuries before, some of which have been incredibly stubborn. I had a posterior ankle impingement that stopped me running for 9 months, but I could tell even if it was 1% a fortnight, it was always moving forward, and this just really wasn't.
Yeah.
So it was proving to be incredibly stubborn, and lo and behold, so this was from February. By June, July, I had completely plateaued at about 50%. I was still unable to really do much in way of sporting function. I couldn't swim because I needed my extension. So anything that exposed me to extension got oined. So I could stoop over a bike, but as long as I didn't have many lumps and bumps, I like to mountain bike rather than road bike, so that was annoying. And even if I flexed over a bike for too long and then I needed to come into extension at some traffic lights, that'd jar it. And if I was swimming, I had to swim with a float across my front, so I could tilt my pelvis into flexion and just kick my legs. And there's only a certain amount of time you can be overtaken by toddlers before my ego got bruised. So I was really limited, and so eventually it seemed smart to go. Well, I'll be honest, I was probably going to continue to bugger along as best I could, and it was on reassessment with you that you gave me my head a bit of a wobble and said, you've got such a clear block, the symptoms are behaving consistently but not improving, and you were in a position, I remember you just saying to me, I'd get that cut out of you. And it was the first time I'd really then considered, because I'm someone who likes to truly exhaust conservative options, I hadn't really recognised that I was being foolish to keep pursuing that just indefinitely. And so
well, you were highly medicated as well, weren't you?
Yeah.
And again, and we're going to cover some of the medications, so it'd be interesting to get your insight into that. But I think there comes a point where, you know, you weren't exercising, it was affecting your mood, it was affecting some of your performance, and there comes a point where, when do you draw the line? When do you go and get that opinion?
Absolutely, yeah, and it was a smart one. You know, the penny dropped, and this is where, you know, the symptoms didn't really change much from then. So it is easier to keep this part of the story shorter. Where went to see the consultant, and we'll talk about that in a bit more detail, I think. But I then, although not straight away, did then go on to have a lumbar decompression. He did a fresh scan eventually because he wanted to see what the state of play was after that incident I'd had in the office. And although the theory was, looking at my first scan, that large posterior bulge had then gone posterolaterally into the right side and affected that nerve root, which had caused the sort of loss of power and the foot drop that we described. And it did turn out to be the case, and it was quite a large lesion that was compressive squashing up against the facet on that side, which is what they decompressed, and it's been a massive success. So I'm giving away the ending a little bit, but it has been a huge success. I sit here now, I had the surgery end of September, was it, I think? Yeah. And so I sit here now at 80% better. I can still find ways to elicit it, full extension, phasing back and returning to sport. There's nothing I picked my board back up last week and started to potter on that. How far I can progress that, I don't know. Will I race again at that level? I don't know. But generally speaking, I'm now confident that I'll be able to do what I want to do do what I want with my body now again, as long as I gradually phase it up. I was off meds by within 6 or 7 weeks. I was off all medication, which was just a huge weight off my shoulders, and so it's been a real success story so far. So I've been putting off having this conversation because I said I wanted to make sure I was able to say that on air, because I think that's really helpful. But it took for that surgery to get there.
Yeah. So I think what we'd like to do then, and certainly I've sort of asked some of the team here some questions that not only myself but they'd also like to try and understand, knowing, you know, when we're health professionals and we're quite knowledgeable, how we can bring that into the reality when it's ourselves. So got a few questions really to get under the surface, if that's all right.
Yeah, go for it. Let's do it.
And hopefully, you know, the listeners will take something away from this. So first thing I'd like to ask you is, for someone who is openly skeptical health professional, Can you talk about how your experience has influenced or not influenced any aspect of our profession that you were previously sceptical about?
Yeah, I mean, I like the question because it's got sceptical in it twice. That's hilarious. So hopefully it's sceptical rather than nihilistic, I hope. And I think I learned a lot. I don't think I'm being too cheeky to say that it's reaffirmed a lot of what I suspected rather than necessarily made me doubt my own skepticism or given me fresh skepticism in a different direction. Because it's the one thing that I would say I would have been more skeptical of is that the way that it changed, particularly in those early stages, as we've just discussed, was something that me and you spoke about it at the time. It was behaving so atypically, everything about my system was in disarray, and felt like I was a rational actor. I at that point wasn't necessarily catastrophic of thought. I was fairly confident. I'd always been able to find a way around other injuries before, yet it just wasn't behaving as I'd like it to, and I just couldn't settle that down. So when then it was a case of this needs to be investigated, that's when that's where I really would change my approach to things with a patient, is that these things can behave in quite the bizarre fashion. You know, it was, if you were to give that as a case study, people would have thought, that sounds like he's blunt trauma repetitively to his backside from quite a height over and over again. It made sense for it to potentially have been spondylolisthesis, particularly within the with that sense of instability. So for it to not be, it's hugely reassuring, but it just turns out that's a large disc lesion that presented that way. Yeah? So yeah, exactly. So that's what I learned a lot from that. How that interferes with my general skepticism, I don't know, because really I'm pro reason, and essentially that's what we reasoned through. So it didn't necessarily go counter to what I've thought before. However, to fast forward though, where it really does reinforce some of the things that we talk about a lot on Physio Matters, and particularly where our minds have met before on Twitter before we first met, is the general disparity between the process that we'd been through in workup, and even with the GP's help with the medication and things like that. I then parked myself in front of the spinal consultant with for an opinion regarding intervention. You know, it was something that, despite best conservative management we can muster, I can't break through. I'm 50% better, but still functionally disabled to a level that I would. And listeners might not know, I'm 29 now, 28 at the time. And sat in front of a surgeon explaining how limited I was and being able to demonstrate my symptoms. And my assessment, despite, again, I'm not hiding from him that I'm a physio at all, not that that should have any gravitas, but despite being as honest as I could with him, I get a neuro assessment through clothes and shoes. I get, and half a one at that, I get a sort of pointing at some things on my scan, and an explanation that this is something best dealt with conservatively, and that he would strongly recommend against surgery. And I then said, well, to be honest, that's I'm only here because I'm only here at this point rather than 3 months ago, because I'd agree with that. But the fact that I've plateaued at this level and just can't seem to breach the next thing, certainly can't go anywhere near running unless I stoop over. I can run about 100 metres if I stoop over. I've tried it, I've played around with it. And he just said, well, running's certainly not something that you should be doing for backs anyway. It's quite bad for your back. You shouldn't be running. I'd knocked that on the head even before this injury. I'd be telling you that even if you hadn't had this. Or if you'd have fully recovered, you shouldn't be running again. I was like, well, whatever. He's like, well, no. And then he said, well, I think this should resolve. 2.5 years it might take, but if it should resolve, and therefore I'd leave it well alone. And at this point, and at that point the weakness was improving, and I was then at about sort of a week 4 out of 5 if we were to grade my power loss. But other than the weakness resolving, everything else was as was. And it was really, it really was. It was affecting my sleep. I was, like you say, fairly heavily medicated, quite not full dose, but sort of 2/3 dose pre-gabalin, 4 zapping cocodamol a day, and that's it. But that was enough. So it really slowed me down. So I did a deal, because I couldn't have a back and forth with him. That was one of the really frustrating things. Is that I then sort of pushed back a little bit against it, but I felt reluctant to, because I was like, I don't want to be that guy. You know, I know what it's like when I'm going counter to his opinion, but he wasn't articulating his reasoning. Yeah. And so I then pushed back a little bit and just said, yeah, but I'm plateauing. In fact, I think and Shah was with me, I think even she piped up and just went, look, we're not having the conversation we came to. Let's have it either. It wasn't even a good patient clinician conversation. Never mind a interprofessional one. Yeah? So in the end, but as soon as I then uttered the case of, well, I see what you're saying, but when then? You know, it's just like I can't really. It just doesn't make sense. I certainly can't live like this for 2 years just on a chance, and we know that would just make things more and more sensitive, less and less time extending, less and less time going in. You know, at that point I'm avoiding a slump position, so my hamstrings are getting even tighter. Something I'm still suffering with a little bit now is I'm having to phase back in to getting my flexibility back, what little of it I had. And so, but as soon as I uttered that, he said, fine, yeah, okay, we'll operate. If you insist, we'll operate. You know it's against my better judgment, but we'll operate. And he gets the consent form out. And I was just like so torn, because I'm like, I'm not trying to strong arm you. So I did him a deal, and I just said, look, I'll come back in, I'll give it, I'll exhaust it to the nth degree. And he said just have another pregabalin a day and stuff like that. And then I'll give it 3 months, and so that's the deal I did, and so I did that, gave it 3 months, did everything I could, and like I said, did what I could in the pool. Worked out that I could row, not on a rowing machine, but I could sort of sit in the back of my canoe. I've got a canoe, and so I'd go out on that, and sometimes, and just did what I could, and just couldn't breach, especially the extension thing. Just couldn't improve that. Yeah. The more I did, the more it hurt. The less I did, the stiffer my back I'd get, but the less it hurt. You know, if I was idle and I wasn't someone who wanted to be active, I could probably have made it manageable, but it wasn't that way. And so in September I went back, and he got a fresh scan, or his reg organised a fresh scan, and he was incredibly amenable the second time round. You know, it was just a different man. Person, he was a different man. He was someone that. And again, didn't articulate as to why, and you just don't know whether it was a mood shift or whether he'd been in light of this second scan, which revealed what we'd suspected, but to an extent that he may be underestimated. Perhaps that weighed in, or perhaps what I hope would be that he saw sense over the fact that I'd given it another 3 months, and the time frame was such that I was significantly limited. And so he then we agreed, and I didn't have to strong arm him into cutting me open. Funnily enough, when they did the surgery, I don't know if I probably have told you this, but I came round, and he thought I'd had a bit of a leak. He thought they were checking me because they thought he might have clipped it, and I had a CSF leak. And he said he apologised while I'm super groggy. I'd only just come round. And he went in off my old scan and went in too low, and then noticed that he'd marked me on my right side. So he looked at where I had that larger left-sided lesion that was old at L5S1, and he'd gone in too low. So I've got like a double-length scar, and he was apologising for that. He thought it'll be sorer than I thought than it should be, because you've got sort of I took more bone away than I took more spinous process away than I would normally, because I went in too low. So he left that alone, left my old thing alone, and decompressed right side L45, and I came round and I wiggled my feet around, and first time in 9 months at that point that I woke up and I had no shin pain. It was that immediate. I could still elicit my shin pain in a full slump and stuff like that, and still to some degree can now. But I could tell right away that nerve had been relieved, and the job had been done to some extent, and my rehab began. So I was 6 weeks off work, gradually built stuff up, particularly once my wound had healed, back in the pool, realised I could swim crawl again, realised I could start to extend again. I'm stiff, but and as I weaned off my medication, hilariously I started to get back pain again for the first time in ages, and other injuries like my left knee, which is missing a PCL, it started to ache again. I hadn't had that because I'd just had this shin pain,
Yes.
and then had all the medication that had been some degree masking my other injuries. Plus, these are injuries that get unveiled the more I do with sport and stuff, and I hadn't been doing it. So I've been reacquainted with my old injuries, but my right shin is no longer on fire constantly. So yeah.
So after your surgery, did you see any physios outside of IPOPS?
Yeah, it was something I probably could have turned down, but I was invited to a sort of session. I didn't know what it was going to entail, but it ended up being in a group, and I was absolutely delighted because when I got to the waiting room, there was the Mythbusters posters that I'd contributed to. Myself and the Physio Matters team had contributed as part of a CSP project, the Spinal Mythbusters, but low back pain Mythbusters, which was out, I think, whilst I was on my 6 weeks annual leave, technically on my recovery. And so I went in and I saw that and I was chuffed to bits, and then every one of those myths and more was then perpetuated in this session that I then went into. So it was weird that they were up on the board, but no bugger had read them, because I was like sat in this. It was like Jeremy Beadle could have jumped out, because it was like they just. Everything that we've ever railed against, everything I've ever stood for in my career from day one, pretty much. I knew from even at uni, you knew that this wasn't a thing. But we sat with these other spinal patients, some pre-op, some post-op, and some that had been turned down for surgery or weren't appropriate, whatever. But there's a vast array of people, most of them older than me. And it was just this broad sort of, let me tell you about the spine. And there is every mistake under the sun was made, where don't flex your spine, and this old chap said whatever, and she said, well, ideally, I know sometimes you'll have to, but yeah, generally speaking. And then she did this demonstration where I'm kind of used to people doing a full hip hinge, just squatting, don't flex your spine, just use your hips, stick your bottom back, that sort of thing, which obviously is a sensible move in acute cases. But I thought, she's going to suggest that that's what you should do all the time. But no, she didn't even do that. She didn't even flex her hips. She did this weird pirouette thing where she went onto the balls of her feet and just went straight down, flat spine, didn't even flex her hips, all knees. It was the most bizarre, unstable thing, and she's lifting this cardboard box to demonstrate. And I remember people in the room, not just me, looking at each other like, what? I can't do that. That's not practical. There's some working people in there. This woman that worked in a factory that was just like going bog-eyed, thinking, what is she on about? I can't do that. And then it was the next question was my favourite. This lady that worked in the factory said, well, why would we have to do that? Why can't we move more naturally than that? And which I thought was a great question. And the physio running this session then said, well, it's because the spine it's not good for it to bend, because the spine's kind of like a series of jam donuts. Well, no, not like jam donuts. And I thought, oh God, I'm glad she's corrected that. And then she said, it's kind of like, because in a jam donut, the pressure, the jam would come out only where it went in. There's like a path of least resistance. It would come out the back. So it's more like a series of vanilla slices, in which you then have the custard can come out the back and the sides. And I was just like, you can't think of a daintier pastry. Like, it's like, and so honestly, that's where I'm looking around. I'm like, someone's having me on here, or they know it's me or something. It's crazy. And so I was absolutely mortified at that, and as was. And some of the people in the room were really lapping this up and making notes, and other people were clearly thinking, this just doesn't seem to suit me because I work in a factory and that's not feasible. Even if she's telling the truth, that's not going to be tenable. Or at least I hope that's what they're thinking, because if with that sort of advice, I wouldn't be surprised if people then went, well, I can't work a manual job again. I've got my spine is that vulnerable and it's that sore as it is now. Then I need to change my work, and the way that will interfere with people's lives based on this incredibly, she seemed lovely, this woman. She's like super well-meaning, but just completely ignorant. And I can't think of a better word than ignorant for that circumstance. And especially in a situation like this. I mean, as I say, well-meaning, but there comes a point of responsibility that I would attribute to her in an age of information in which, like this, we've got an awful lot of stuff out there for free. I think it's starting to become inexcusable to be that far behind. Because I was frustrated, as I mentioned before, with how behind it felt that my surgeon was. But he was in sort of light years ahead of the advice that was then being sold to his post-operative patients in a physio department, and so that was a real frustrating thing. And so it was from that was my one and only physio session in which I managed. Me and my vanilla slices went elsewhere for the rest of it, and I came back home to IPOPS, and I've been all right since. Yeah.
In contrast, a friend of mine's just recently had a similar thing, and it was nice that she asked the surgeon, how can I sleep now, because I've been sleeping in a certain way, and he said, whatever's comfortable, wherever you're comfortable is the best place to sleep. You don't need a new mattress, just move. You don't need physio, just move as you feel comfortable. And I think, it's getting around the country that there are pockets of
that's right.
Areas
That's
where
good.
the good advice is coming through.
Yeah,
like you say,
for sure.
It becomes unacceptable.
But it's weirdly, it'll say that now, but in a couple of months, if the right bed manufacturer slips him a few quid, he might change his tune. But I know I'm being.
Let's hope not.
That's the sceptical cynic that you were talking about earlier.
Oh, excellent. Well, talking about your medication, and like you say, you were taking quite a cocktail towards the end. As health professionals, we can often feel frustrated when our patients don't comply with the medication given to them. I wonder how the medication that you were prescribed affected sort of your day-to-day function, both as a person and as a clinician, and how it subsequently affected your ability to comply with using it.
Yeah, it really did affect me. And pregabalin, famously a lower side effect profile, though there's arguments from what I understand that might be some pharmaceutical spin to some degree, because I did feel it slowed me down, and it's designed to in a sense, but it just felt like it slowed my processes. I do think fast, I talk fast, as everyone knows, and so particularly for a window in the morning, I wasn't necessarily that groggy. I didn't get a hungover feeling that sometimes patients will describe from these things. Instead, it was just more that I just wasn't as sharp. I think
some of the team were quite pleased about that.
Maybe, yeah, less sarcastic, they'd argue, and less witty, but yeah, just a bit sluggish, and therefore found myself coming I have a habit of coming out from the curtains and stuff when a patient's getting changed. I pace up and down, and the team will know that of me. But I found myself doing 2 or 3 laps pacing rather than the one, because I was just that bit slower reasoning with stuff, and especially in my morning clinics, that definitely affected me. And as I say, I'm up at 5 and getting a train and all that stuff. I'd normally be waking up at that time, but then cycling and running up from the train station and just be on a heightened state by the time I got going at my 7:30 start, and that just wasn't happening. So all of my normal processes it wasn't just the medication, it was what the medication was doing to me, as well as the loss of function that was just totally blitzing my routine. And I'm thinking, how much of this as well is just that I'm not sleeping as well, or I'm getting these artificial.
Not cycling, or you're not doing.
It all feeds in. You can never say it was just the medication, but it definitely was influencing it, and part of the process, part of what was helping, but also part of what was hindering, and that really did start to phase me. I'll admit, it never really. It was. They were both, the cocodamol and the pregabalin were so helpful for me, and I could tell they were, that I never really had any doubts on compliance. It was just a case of sort of just keep cracking on. And instead it was just about making sure I got into a routine, made sure I was regularly just maintaining range of movements, particularly spinally, apart from extension, which I was doing as best I could, but apart from extension I was able to maintain a good degree of mobility, and just kept stretching through, making sure I wasn't getting too tight. and then meditating most days. Apart from on my those busy longer days that I have, sometimes I didn't get a chance to, but certainly most days of the week I'd spend some time, 15-20 minutes, just meditating. I'm not the best at most focused mindfulness, but generally just taking some time out and relaxing off, and that really helped decrease some tension and get my thoughts in order when I was processing things slower.
Yeah.
But it definitely affected me, and it's something that I think, again, I don't want it to sound like I was already there, but I feel like I've always had a lot of empathy and sympathy for those things, with those things, but I underestimated just the depth in which it can really affect your sense of self. And it's not just the medication that does that, but just the way it was interfering with everything about my being, over this just machines on fire.
Yeah.
And it wasn't the pain, it was what the pain was doing to my function. It was what the pain was then. The pain was, talking about it like it's an entity, of course I know that's a bit of a fallacy, but it was interfering so much with what I needed to be doing, and the medication feeds into that for sure. But you thought it was worth it though, by the sounds of it, because there was never a doubt there. Yeah. No, it was definitely worth it, because I mean, I could have been sharper, and I could have been. You did try though. You did try to. Oh, I dabbled a couple of times. I tried
your
weaning.
Dosage, didn't you? And it was a no-go really.
Absolutely.
You struggled more. So maybe the ones that don't comply, maybe it's because it's not helping them enough.
That's right. I mean, I tried weaning down, particularly from the codeine, because I was getting the typical side effect of constipation with that. Yeah. So I tried weaning down from that. Could I supplement that and just take paracetamol instead? And it really that made a massive difference. I couldn't handle that, and it would have taken me off work. And at this point, I'm working half time in the NHS with IPOPS. And I wanted to retain that and maintain, and then so what I was doing is I was adjusting all my routine and having other staff see some of my patients and back off some of the clinical stuff I could do as my own boss, and was working at a desk, and that had something I'm glad you've just reminded me of, is that really affected my earning potential. I suddenly no longer could sell my labour. That's where I make decent money, really. I mean, the business, you can tick it over and you can send other people in, that's fine, but my best chargeable time is when I'm doing a second opinion for an athlete at an athletics club, and I've built a career off being the guy that will do the hurdles with the athlete. You know, I'm very hands-on with that, at least in that term of hands-on. So so you lost that. I was fully compromised by that. I mean, you still, I'm not going to say my reputation went down the pan, but it was just I knew I couldn't be that guy, and so I couldn't compromise everything, or even just getting to and from these things. I knew that if I wanted to retain my NHS work, and I was a trainee ESP at the time, and so I wanted to keep that going as best I could, even with my slowed faculties, I had to compromise that and at least be somewhat restful in my own time, or my own sort of work time, where I was able to dictate my life. But now that is an incredible privilege that I had compared to many patients, and if I had a job in which I couldn't make those adjustments and didn't have the capacity to be my own boss for the majority of my week, I don't know where I'd be. I think I would have been. I would have had to walk that back, and so it would have been a very different story. So there's a lot of misfortune and fortune intertwined with it, but that definitely played a huge part, and that affects your sense of self as well. If you're not being the person professionally that you were known for, that starts to throw you as well.
Well, Heather would agree with that. You know, we are defined by our work as well as our personal being, aren't we? So it impacts us on us. So you've mentioned you love a sport. You mentioned how you like your higher end activities. So your symptoms, the impact on your ability to undertake your level activities, what effect do you think not being able to do them then had on your physical and your psychological well-being? So you've talked a little bit about it, but just that lack of function at that level.
I think worth mentioning that some of what might be obvious, or patients certainly bring it up, but despite best efforts, and I don't mean complete best efforts, because I could have, relatively decent willpower, I think people would allow me to say. But I, over the course of the time I was off, so between the February and the September, bearing in mind I did my first triathlon the November before, I was purposely training up for, and got this new board for a season where I was going to at least pretend to be an athlete again and see if I could race in the World Championships, for example. So I was getting into shape, and I put 2.5 stone on, certainly. Maybe I've over-egged that a little bit, but I certainly put weight on and lost a lot of tone, and to put that weight on despite losing the muscle, that tells a lot. And I could have probably decreased that amount of weight I put on, but what is interesting is that you're not getting the endorphins you used to, and you become, even though I was managing it okay, and I wasn't super sulky, and I managed to sort of have a lot of other stuff going on. I didn't get too down about it, but I definitely would treat myself to and let my diet slide far more than I knew was good for me. And when just basic things like I would typically be cycling back from the train station, and instead I was in the car, and suddenly KFC's lights seemed brighter. Stuff like that just made a difference.
You're not getting that feedback loop. Whereas if you eat that stuff, you don't want to run the next. You feel groggy, so you don't eat it normally when you.
Exactly. You're full of fried chicken. Yeah, you get.
So
you
don't
couldn't
do
go.
it.
And I'm already groggy in the morning. I'm not needing to exercise. I'm therefore not getting the feedback loop where I have a bad run and it tells me that. I also just the compromise of what exercise I could do meant I was at such a low intensity. I mean, it was just pottering whatever I did. Meant that I was never getting that that feedback that you described.
Yeah.
So that made a real difference.
Yeah.
And psychologically, it really I think a lot, full stop. I mean, I am a deep thinker. There's no act put on there on these podcasts. I do think as deep as I can about issues, and there's an awful lot going on in 2016. Not just in my life. There were a lot to observe and a lot of thinking to do. And just because I wasn't physically able didn't stop me being a commentator. I was still across social media, still podcasting, of course. So I was still studying, and I realised just how much I go through things when I go for a run or when I'm out on the bike. More so when I'm running, really. It's something to do with the rhythm. It's a beautiful thing. But I've always run. I was brought up on the fells, and so to not be able to do that was hugely stifling for my psychological well-being, which is why I brought in some of the meditation more than I normally would have done before, and I changed my habits, decreased my decreased how much I was listening to, because I was overindulging on podcasts and radio shows and stuff, and started to pick up more books again, and so I just managed to and caught myself up a little bit on where I felt my cognitive processes were slower. I was able to find time elsewhere and just change my tactics and shift
your attention somewhere else, maybe.
Yeah, which was good. I mean, it was good for me. I would argue 2016 was a funny year for me, but it's certainly a bad year for any of my adversaries. If people, because what it did is it meant I just sharpened up where I wasn't. I mean, people might still think I've got gaps, and I'm sure I do have, but I was able to read widely. I certainly broadened my horizons in what was a complex year going on with especially current affairs and stuff like that. Just meant I was felt like I could spend more time sort of observing and found myself sharpening up. Even though I was feeling slower, I was able to work more on myself, and what I couldn't do physically, I felt like I still grew as a person, especially looking back on it now.
Yeah, so some positive out of the negative of it.
Definitely, yeah.
Do you feel that having a personal insight on the impact symptoms can have on our lives has changed the way you may approach this problem with your patients in the future? Yeah,
I think that the way in which I realised just how intertwined things were, you couldn't attribute. I mean, it's the attribution of causation argument again, is that you couldn't, like I mentioned before, you can't say, well, the medication was affecting this. It's like, well, I have no idea if it was the medication. Was it the medication, the loss of sleep, the inability to exercise, or the pain that was tiring? You just don't know. They're all intertwined. And so because it was so complex even within myself, even though I should have insight, and even when we were discussing it with colleagues, it wasn't as if I was making complexity out of something more straightforward. Everyone saw it as being an interwoven mess. I now realise just how no amount of questioning is appropriate with patients. You should go deep, but you'll never go deep enough. So no matter how much you feel you're getting to know someone, especially in an assessment situation, and even I'd argue if it was friends and family and you feel like you know how people tick, don't kid yourself. You haven't a clue, because I didn't know how I tick. I still don't. I would argue I couldn't work it out. I couldn't parse out the differences. And so there's a certain level of depth that people should go, and it's important to elicit this information. But if it's not coming easily in a conversation, and if someone's either, it might not be that they're withholding it from you, it's just that they don't realise it themselves. So be probing, and that's fine. But yeah, it made me realise just how I feel like, especially with the interviewing that I do outside of a patient contact, I feel like that's where my strengths lie, and I think most colleagues suggest so. Patients know I can natter, but generally that's where I feel like but even with those skills, that I realised just how much I had still been scratching the surface, and that's okay. You only go as far as you need to, because the way in which it becomes so intertwined and messy, particularly as time passes, because there's more in there, there's more in the vault, there's more to pick through. So getting, I'd always advise friends and family and patients now, whereas historically I might have suggested that, no, it's worth trying some stuff for a period of time, and there's these sensible time frames of months that can go by for these typical things to recover, and whilst sometimes that's appropriate if someone's in the know, but if they're not, now I realise that just to present at 3-4 months with something that might end up becoming complex, you've then got a lot of baggage that you've got to try and pick through. And so my hunch now, particularly if you've got access to good quality care, which I know is a big if, because of the reasons I mentioned earlier with the disparity between our ideas and the surgeons, is that if you can guarantee a good person to put someone behind, I would say early intervention, at least for assessment, is a smart move to get the pen on paper. And you were right to sort of push my hand a little bit onto that and say, no, let's have a look at it at 2 weeks rather than 4 weeks, because there's just less to go through, and it starts. It was just
as an observer, seeing how it was impacting on your quality of life, and I think sometimes are trying to make sense of it yourself because we're knowledgeable, we're trying to understand the descending inhibition, we can sort that out. But from an outsider who's also in the know, to watch somebody deteriorate, you can't just have a bystanding and allow that to happen.
And there was some stubbornness, particularly early doors. I was just cracking on. There was this like
denial,
false bravery, a bit of denial, and because you do. I'm not someone that would start professing to have a particularly high pain threshold, but I do think, because I'm used to bumps and grazes and scratches and falling off from various heights and learning how to fall, and as I say, and rugby and things like that as well, just means I think I do have an understanding and a good pain tolerance. I think I've had plenty of injuries that I sort of manage that make me better at that, and so to have probably been just sort of bundling through and crossing my fingers was something that wasn't that smart. So I would, to go back to your question, yes, it has influenced me greatly in probably pointing people towards an assessment sooner than I otherwise would have done beforehand, because
just to get that baseline.
Get the baseline in doesn't necessarily mean intervention.
No.
But to get the cards on the table is often the metaphor I'll use with patients, and I'm more of an advocate than ever before.
Because of this experience.
Yeah, for sure.
Excellent. Right. Within our roles as ESPs and any health professional, really, I think, we try to promote a balanced and open-minded, reasoned process.
Mm-hmm.
I wonder, given what you know about spinal pain, whether this was possible to apply when it was your own personal experience, or whether there was ever a tendency to be catastrophic with your thoughts regarding potential diagnosis during the early stages. And I know you've tapped on a little bit, didn't you, about this low lysis and things, but is there a tendency to?
I feel like it helped more than it hindered, apart from that potential there's a few days there where it's like, have I fractured my spine? You know, you just get this raw, visceral, emotional response where it doesn't matter I could have a cluster of degrees to my name that were relevant to the thing. I think I could have been a spinal surgeon of decades experience. It still is this sense of instability a true representation of an actual vulnerability of my spine right now, having just bluntly landed on my backside over and over again. It made too much sense for it to be so. So I think there was this window in which potentially that those top-down emotions started to drive through, and there was no fighting it. But generally speaking, and it would be fun because I'm sure we've got colleagues that would love to bait and suggest that I was catastrophic for a long period of time. But certainly I feel like apart from that window, it was something that my knowledge helped more than it hindered. I think as well, I wouldn't have been able to stay in work and manage it as I did if I hadn't have known what to do. Partly because as well, it was so sensitive for periods of time, especially I knew how to, I think anyone would have worked out that he didn't like extension. But particularly I realised that when I was sat around at home and stuff, I needed to not be bolt upright, but I needed to not be putting myself into neural tension. I needed to not sit up and read in bed. I needed to not be in a long sitting position. Not a smart move. You can get away with it at the time, but then I'd get latent pain, particularly into the night. And I'd realised that. And a patient might not have realised that's what had caused it. They'd just think maybe I overdid it the day, or it's just a bad night. Or you know what patients are like? Pathology's getting worse, or I need a new mattress. You know, people do it, don't they? So I fortunately didn't make those mistakes. So I feel like it was more of an asset than it was a weakness. But I accept, in the spirit of the question, I definitely accept the fact that it's harder, certainly at times when it's yourself, when it's within you, and I've got as much sympathy, if not more, than I already had for patients trying to articulate these things and to be misunderstood, particularly if someone isn't wanting to listen. And I was fortunate, particularly within the physio care, of course, to not have that, but just in those little windows where I wasn't feeling like I was being understood by surgeons who really had a key influence at that point on what my future held. Had I not have been in the know, I wouldn't be sat here in as little pain as I am now. That's a matter of fact. So that's another place in which my knowledge helped rather than hindered. And I think with the emotions of it all, I know full well just how bad these things can get if they're allowed to become incredibly sensitized in every which way. And so to keep myself well in a mental health sense, to find ways to make sure you establish and retain relationships with, of course, my closest, nearest and dearest, but also to not become socially isolated, to remember to be a boss of a kind where I needed to not let my staff down, as well as to still muck in with other things in department here. You know, I knew full well.
Patients wouldn't have known.
Well,
you know
I'd hope not. I'd hope not.
There was never any question about you being safe or competent during any of the time. Because obviously we'd have managed that. And like you say, that's the knowledge you've got that kept you at that functional level.
I think
although it was reduced, it was still at a level.
Yeah, well, I hope it was competent. I know we use that word a lot, but I think that is. I've just articulated it now, do I realise it actually took some conscious effort to not just regress to doing less. So I'm actually, as I say that now, I'm realising, there were a lot of sort of dust yourself down, grit your teeth, wince a bit and then crack on. And without that, I know the comfort zone I would have regressed to would have been to have not seen as much of my friends and to probably have been a bit shorter with the loved ones at home, or to have been just doubled down on some of the more straightforward tasks at work, and instead and so I could therefore understand why patients would do that if they didn't have the knowledge that I was fortunate enough to have.
Despite your skepticism to passive treatments,
that word again.
Was there any point during your journey that you actually just wanted a nice rub.
I love that. I mean, it's funny.
You never asked me, and I was waiting.
Yeah, I bet you'd have had a camera ready, wouldn't you? It's a great question. No, and I think it perhaps shows the depth of my skepticism, maybe, but also, and it wasn't out of stubbornness because I didn't want to succumb to it. It was more to do with, I feel like my skepticism comes from what I feel is a decent understanding of the mechanisms, and therefore to have wanted what is essentially, in my mind, a form of pain relief.
Yeah.
When that was one of the things I had in hand. You know, I was actually finding a way to keep it at a level, and so I don't think if I'd have introduced some form of manual therapy or any other adjunct, would I then have been able to take less medication? It just didn't seem sensible or feasible to be wanting to do that. Would I wanted to take that risk, having tried to dabble with it before with the medication and it not gone well? It wasn't worth the faffing with when I was finding a level. Would it have, would some manual therapy have meant I could tolerate extension more? I just wasn't. I couldn't comprehend it. One thing that's interesting is I went for a beer in August when we were on holiday. It was painful because I was in Newquay on holiday, which is where I usually go surfing, but we still went down there, but I couldn't surf. I went out in the boat a couple of times, which was fun. But I met up with Paul Coker, a good friend of mine, podcast guest, and he was telling me, and we didn't talk much shop, but he just saw me hobbling in, and he knew about the fact that I hadn't been surfing that week, and he just said, you know, what have you got to lose? Just try it for me. And so he told me just to map down the leg into where my symptoms are with some rock tape, and I did. I think I might even have been caught out by a colleague having left it on to follow it because it sticks forever, does rock tape. So I still had it on coming into work that time, and I pulled my socks up, and I think Steve or Tom caught me with it on. But yeah, and I would be honest and say that it made a difference, but I can't think it did. I honestly think in circumstances like that, I think one of the ways it could have done is when I put it on wrong and it was tugging on my hairs. I think it was a sort of pain gate of a kind, I suppose, but I would admit it if not. But that's the only adjunct I ever dabbled with, and that was almost as not a favour because he wasn't begging me to, but he was right to say why not. Whereas that was something that was, there's no time, it didn't take me any time at all, and it was kind of a case of why not bother. And what was interesting is one of the reasons I would argue to not bother again if that happened in this circumstance. Although I've used rock tape to effect before on my knee, for example, so I'm not dismissive of it, and I'm not dismissive of manual therapy. But in my circumstance, with the way it was behaving, and the lack of variability that I had, it was becoming consistent. I'm a man for consistency, and I say that with patients all the time. So I wouldn't have. There was a point in which I stopped faffing around with it. You know, I just needed to try and just keep chipping away, especially when it got towards at this point. So I'm talking about me seeing him in August, and any time I'd have been reaching for a rub or just some cheap relief was in and around the time that I'm realising that this isn't moving forward, and I was setting the scene for me to have the surgery, and with that comes all the things I had to put in place with regards to the business, and thank you, worth thanking Mark Reed, our clinical lead at Choose Health, for covering my patients and taking on more there and stuff like that for when I was there. So all the things were being put in place, and I never found myself, unless someone's going to pipe up and say, oh, he was begging me for a massage, I'm going to get some sort of there'll be some sort of Daily Mail-esque article exposing me sneaking with the chin putty on into some sort of chiro clinic or something. But I don't remember asking anyone for a rub. I don't think so.
What additional skills do you think this experience has given you that you don't feel you necessarily had prior to your pain and the surgery that you consequently underwent? You've already mentioned that again. That just that awareness of how patients you could understand how they could retract even more and more if they didn't have that mindset, they didn't have the knowledge.
That's it. There's the two things I've already mentioned. So there's the fact that I think impulsively people will retract, and I understand that better than ever. I'd seen that happening, but I'd never understood the mechanisms almost behind it, that protectionism that you have, which we're hearing that word a lot these days in other circumstances, but protectionism being just this withdrawal that you would have to just self-preserve. I can get that. Also, the thing I said before, the understanding of the line where probing is sensible, but don't kid yourself into thinking you can get it all and understand it all, no matter how intimately linked you are to that case. I think that's something I could have previously been arrogant enough to kid myself on. The third thing then is what skills have I developed or learnt. I have started to, it changed some of my, the language I'd use when I'm teaching some of my colleagues about these matters have changed slightly, in that I've come to realise that it gave me more crisp, defined lines as to when to escalate things. Part of my ESP role being to onward refer in appropriate time frames, and particularly when things are pertinent and urgent, and when we were dealing with hard neuro, there were certain dividing lines there. But more than anything, I mean, one of the lines that I found myself using more, I don't think I've come up with it since, but it's treating general things generally, but if something's a specific problem, you can treat it specifically. And in this circumstance, there were certain things that were improving, and then there were certain things that weren't. And my ability to tolerate any degree of extension in any which way, or even to try and exercise into flexion and then exercise gently into degrees of extension. And so I was like stooped over my bottom step at home. Could I run up and down my step in flexion? Yeah, I could, but I'd have to extend at some point. And so if I didn't do that, would I just end up being more flexed over, just living with a sort of a flat back and quite a lot of tension through my paraspinals trying to maintain me there. And I caught myself doing that sometimes, particularly when I was on my bike, and particularly when I was having a bit of a stubborn day, and I'd grit my teeth and do an extra 5 minutes to try and get out of breath because I wanted to get some aerobic exercise in. And I'd suffer the consequences because it just wasn't a smart move for me. And so what I learned is that it's smart to just find yourself recognising the limitations of not just yourself but of physiotherapy. When you really truly are exhausting your conservative options, that is still standing you in good stead, but sometimes interventions are required. I don't think I've ever been too blocked on those things. I feel like this is where you might correct me if I'm wrong, but I've not had cases in which notes have been pulled by yourself or Denise to say this surgical referral was delayed by 6 months than it should do. But generally now I realise through your help as well that I was blinkered a little bit away from surgery because I felt defeated, and I never realised until the moment came where I was having to sort of throw my hands in the air and say, I'm at 50% and it's nowhere near good enough, and I want my life back, and I need a scalpel. And despite having been offered surgery for this posterior impingement in my ankles, the only other example where I've ever been on the cusp there, I've got this osteophyte, still there, but I managed it conservatively. And I remember being so proud of that, sort of, because I was able to use my knowledge to box clever and work around it, and gradually it settled down. And I always sort of thought, particularly in the early months of having this injury, that I'd be able to work a similar thing, particularly with the regression that we know discs have, and just give it time. And it just never came, and so I did. I felt utterly defeated, and so it's not a skill as such.
I almost remember the conversation when I said, Jack, when is enough enough? When are you going to say this is not improving? Yeah. You know, I could see it. I could see what it was doing to you, and you were trying so hard because of your knowledge and because of what we know we can.
And I remember saying to you, didn't I? I said, well, you know, you don't escalate it that far. What about maybe I could get an epidural and just see if I could try some more extension? And you just said, that makes no sense reasoning wise. You do this block to extension that's just giving you as soon as you, I mean, especially I remember it clearly where just as soon as I tilted forward, it was like bang, shin pain. So it was just so clear and so sensitive that it's like, yeah, of course you might get some relief from that, but it just felt like there was this inevitability that I was limited at too low a level, too low a grade. And you're absolutely right to encourage that process, especially when I then needed to arm wrestle the surgeon into doing it seemed, and that took a bit longer than we'd have liked. But it meant that I'd had a best part of 9 months, really, where I'd truly given it my all and can't have any regrets there.
No,
and therefore...
And you did. You tried every modification, you know what I mean, to your movements, didn't you? You were really exploring everything we know that we should explore to the nth degree, and I think there comes a point that, Jack, come on. Do you want to live your life like this? What else are you doing about it?
And I'm glad I did what I did in a sense, because you just don't know. I mean, I hit the ground pretty much literally running, didn't I? Once I'd had the surgery and it calmed the shin pain down, apart from the natural tenderness and sensitivity that comes off the back of the rawness of the scarring and stuff, you know, it's been brilliant, because whilst I said I put a bit of weight on and I obviously was unfit, particularly aerobically, I'd retained range of movement and I'd not lost completely any capacity to do things, and certainly therefore not lost any confidence. And just once I phased back into realising I could tolerate extension without getting this searing shin pain, then we were winning. So that was I'm glad to some degree there was enough of a delay. I certainly wouldn't have looked back on this and think, I should have had the surgery at 4 months. I'd never have done that.
You needed to have gone down that road.
And I needed to do that, to be honest with myself, because like I said, at the time of having the surgery, I felt defeated, and now I look back and realise that was a bit petty. That was again just a bit of sort of plucky arrogance almost, to think I could have beaten it and beaten biology was the thing that made me feel defeated, whereas now I look back and just think I was being silly, and so I've learned a lot there about myself. Exactly. You can't have any regrets there. And nourish your patients. I think that's one thing, you know, if you apply that to patients, never mind just spinal patients, but just think about we need to make sure we don't scaremonger. Sometimes it's helpful for us, and sometimes it feels like a weapon to sort of say to people, well, you certainly don't want surgery on this. Let's just use an OA hip, for example. You know, got a moderate OA hip. You're trying to motivate someone to exhaust the conservative options, and we know that that's sensible, but try and do that without demonising the surgery, because you never know when that might bite you on the ass. As a therapist, never mind as a patient, you know, you're giving them sleepless nights 6 months on when they're realising that they're not doing very well and they're worsening, but they don't want the surgery because you've told them how scary it is. You know, there's no need to do that. And so with spinal surgery, I see that a lot. Fortunately, I don't hear it behind our curtains, but particularly in other departments I've worked in, when I was even pushing my luck and I was worried about money. If you remember, I started doing some locum and stuff, and that was a brief blip that Charlotte soon wound my neck back in, where I was getting concerned about it, so I started doing a bit of locum in. And the reason I mention that is because that I realised there that behind the curtains in some departments, a tactic that was used to try and make someone engage with conservative management was to utterly demonise the alternatives, and I don't like that. I don't think I've ever been that way, but I think that it's always a bit tempting to be that person when it's the low-hanging fruit, isn't it? And so we want to make sure we don't do that.
No, that's a really good point. So if you were to reverse time and start this process again, what would you tell yourself to do differently?
Oh, that's a great question. I would certainly not have a 2.5 hour session when I'd only usually been doing 90 minutes. I would have therefore not fallen off as much as I did. And the first time you use a new mountain board shouldn't be in a skate park where they're not designed for. So I'd have probably potentially not have made that mistake if I'd have, you know, that's the thing, is that we say about incremental grading, but what I did is I took something that was a complete comfort zone of mine. You know, I'd do 90 minutes in there and not fall off and do some fairly high level stuff in that skate park. I even know that particular skate park well. But to get a new board that was behaving very differently, I thought that was just one variable when it wasn't, and so that was silly. You know, so I would learn from that, and I'd realise that I should have taken that board to some basic stuff and to a tracking which I was definitely not going to fall on, that it was designed to be used on, and therefore and some softer ground to land on than the concrete that the skate park had. So that was one thing, you know, it seems too obvious, but I potentially wouldn't have then made the same mistake.
Yeah.
As for how I dealt with it, I think it's been a useful journey, so I can never really have too many specific regrets. But I think that looking onto it, if it was to happen again, particularly, I don't think I'd have needed the encouragement and the prods that I have from people like yourself and other colleagues that were able to sort of, and Charlotte as well, my partner, to wind my neck in sometimes where I was getting carried away or stubborn. So I hope that next time round I wouldn't need you to say, come here, come on, let's have a look at it. You know, I've blocked out this bit of time. Or for you to have to say, you're being silly now, it's time to see a surgeon. Or I think I'd probably been able this time to realise the burying my head in the sand at times. So not a regret, but I'd probably do that differently. As for management, I'm pleased to say that, especially now that I'm doing well, I can't really regret any of that. And especially the things, even when it was in darker times, and it was a really awkward and crappy year in so many ways, but I still managed to find some ways and positives around it. We had a couple of setbacks with regards to the business, just coincidentally at the time, which was interesting. And so I was pleased I never went in off the deep end, didn't get too mopey about it, but I just reshuffled my hand a little bit. And as I say, I studied hard in different areas and invested the time that I couldn't invest on my physical being. I did so in my emotional and sort of intellectual being instead, and I'm glad I did, because hopefully that'll continue to
repeat that again, you know. That would be something you'd encourage even patients to think, you know, just redirect your focus a little bit somewhere else if you can.
That's right, yeah, because I think instead people would just double down around some of the lethargy that's just so tempting, you know. As I said before, it's just so easy to regress, and I can understand the impulses and the emotions that would take you to that. And so, yeah, if you can get your patients to just think, well, look at this time that you would have otherwise been doing this. Instead, what can you do? You know, I had a patient the other day in which I suppose I did that with. I wouldn't have done that necessarily 12 months ago, which was that I said, look, you're not running at the moment, but you're saying that you're getting a bit sulky and you're realising how rubbish TV is. I was like, why? You know, I think you seem. It doesn't seem smart, doesn't that? And so he came back in. I didn't make any suggestions other than that. I just said, like, that just doesn't sound like you. I think that's what I'd said. You know, because he'd be this particularly active bloke that was just getting a bit understandably frustrated. Yeah. And he then came back in. He said, you know, I realised I was copping out, and so I've the time I would normally go for a run, he was one of these clockwork runners at a certain time every day, and he was doing extra time with his daughter, doing some homework with her, and it was just something that he said, why was I spending that time feeling mopey and just watching an extra half hour, an hour of telly? That wasn't smart. Instead it was, I couldn't play with the kids, but I could help them with something more useful and functional and something more rewarding, and they appreciated it. So he volunteered that, and I suppose I instigated that in a way that I might not have done before, because I realised that reinvestment in time is a useful thing, and just because when one door closes, the other one opening, I suppose. And fortunately, now that I've got all doors open again, it's made me realise that I should divvy my time up and make sure I look after working on my weaknesses. I'm fairly good at that in a sporting sense. I'd recognise that if my pace was off, then I'd go and do some sprint drills. But when I was reading and learning, and I'd walk myself into corners of knowledge that I wasn't as comfortable with, I had a habit of dodging them. Whereas what happened last year is I realised I had time to go into those corners and try and work out where my blind spots were. So I'm glad I did that, for sure.
And I think, if anything, that certainly helped me think, maybe I'll use that with my patients. That's not something I think I explore, years of knowledge and expertise I've got. That's certainly not something I didn't think about. So
doesn't come naturally, does it? I suppose is that because I suppose we've got to be mindful not to start making suggestions. You know, imagine if I'd have been cheeky enough to
just
say
that little tweak. You know, just
spend more time with your kids. I would never have done that. But yeah, just
put the seed in that mind, and you know, I don't think that's something I've particularly done. So that's been a great insight. Cool. Final question. Mm-hmm. So clearly, the symptoms that yourself and patients develop when they experience back pain and radiculopathy are multi-system and multifactorial. But looking back, what do you feel symptom-wise was the most bothersome to you, and which one would you have wanted to eliminate first, whether it be the pain, loss of function, sleep deprivation, worry for the future? Sort of those.
Because it's me and I'm a waffler, I'm going to give like 3 answers to this, so forgive me. But the most obvious one that sort of strikes me straight away is just how acutely worrying having flaccid tone is on that big toe for that period of time, and that was something that was. It's sort of the novelty or the funniness of it sort of. It wears off fairly quickly after a couple of days of thinking, okay, I want this to turn around now, because that's not cool, you know, just how much is that being compressed, and because that would have meant, if that hadn't turned a corner, then it might have escalated things much faster. Yeah. Fortunately it did, but I would say that it'd be a cop-out answer for me to say that on its own, but for that, when it was particularly flat tone, yeah, that was a real priority. Suddenly it still hurt like hell in the shin, but particularly that was a concern. If someone had said I've got a magic wand and you can have one thing back, it would have been that power right away, because I was realising just how much that would affect me. And if I'd have managed to abolish the pain but still I wouldn't have been able to clear my toe, it would have taken a hell of a lot of retraining to run on that foot. You know, I was overstepping. It was weird, so strange.
Proprioceptively very strange.
Definitely. Yeah, I mean, I was tempted, if it had lasted longer, I'd have been tempted to start trying to rig up some taping strategies and stuff to sort of splint my toe briefly, because I just felt like I was constantly catching it. Less so in shoes, but particularly barefoot, which I like to wear. I like to be barefoot at home, and particularly, you know, not that I live by a beach, but something about, I do wear flip-flops a lot, and I love to be barefoot. I like to run barefoot in. Especially on grass and beach and stuff, so that would have been a real big deal for me, and so I'm glad that turned around. If I was to consider lack of ability and lack of function to be a symptom, which you can't really, it would have been a cop-out, but that is the main thing. It wasn't just the pain, it was what the pain was doing to my ability. But the true answer really is the shin pain, the burning pain that I had whenever I did anything that was slightly above what I'd managed to work out as a threshold. Example being, I went on a stag do in Bucharest, and whether I should have been boozing as much as I was on that medication, I'm not quite sure. I never checked the BNF on that, but generally it was interesting because I found myself in a situation where the apartment that we were in as a large group of lads, was further away from the city than I'd have certainly chosen. But it never really mattered, because I thought, we can just get a cab. But if everyone else, the weather's nice enough and people have got a few bottles, and instead of getting that, they walked it. And so I would have been in a cab on my own. I wasn't going to be that guy. So I just sort of thought it'll be okay. And it wasn't. And the consequences I suffered after that holiday were massive. It really flared it up for a couple of weeks, and I was limping and I was hobbling. I was cursing myself for being silly. Great holiday, great fun, but again, several factors at play there. And so the pain, rather than anything else, and what it then did to my function was the main thing. And I'd be lying to otherwise. I think one of the things as well is that the pain that I was getting and the way it was behaving, particularly into extension. So if I was to pinpoint what it was about loss of function, it was my inability to tolerate any extension. Now there's the obvious stuff like running, like walking for any distance, like certain positions that you want to sit yourself in, that seem obvious. But there's also certain things that, and she'll absolutely murder me for saying it, but and so no one tell her. But generally speaking, it's just the ways in which it can affect even the most intimate parts of your life, and to therefore be at 28 and to have to then go 9 months without being able to have missionary sex completely undermines your general roles and responsibilities, or the way in which you'd instigate any relationship, sort of a romance, shall we say, because there's absolutely, of course, no need for us to be crude about it, but the way in which you'd naturally sort of express yourself becomes different, because you just suddenly okay, I'll roll onto my back again. There's something very strange about that, when especially if it's a shift in role. So that was something that it's a lie to say, oh, it's just because I couldn't extend. It was because of pain that you just couldn't do that. And so you then just realise that especially because it was so consistent. Like, it wasn't like some days I could tolerate extension. It was all, like I said, almost like an on-off switch. Meant that you just did everything you could to adapt to just not going beyond neutral and to live in flexion. And so, as that example shows, you're never going to elicit that with a patient specifically, but it might be something that they volunteer. And if they do, don't underestimate just how much that affects them, because it's not just about the act in that circumstance. It's about what that would then could have done, particularly if they had a less understanding partner, could do, or let's argue that I was dating at the time. I mean, well, just imagine that. Like, I thought about this at the time. We talked about it at the time, and laughed about it at the time, because of course it was never going to be anything that became a massive issue, but it would have been. You know, if you were dating at the time, it would have been a big deal. So, you know, I'll never, and I don't think I did before, but now I'll never underestimate the subtleties like that of how it really compromises people's sense of self. We end on pain because it's an absolute. We rightly focus on function, but a lot of the time, and it certainly was for me, that pain was the thing that was interfering with my function. And in this circumstance, the structural lesion was decompressed. And since then, I've been able to rehabilitate to my now 80% situation, which seems to be going on and up and up. So, we learn a lot of lessons, and I hope the listeners do too.
Yeah, well, thank you. It's been an absolute privilege to have an insight, and, you know, I felt very privileged to assess you and monitor you and guide you and have you back, you know, fully functional, fully fit.
And just as useless as I was beforehand,
rubbish.
So it's good.
Rubbish. Don't listen to him.
No, and thank you so much, of course, for your time and patience and persistence as well, and as well as shout out to all the team that have sort of been there for me and made sure that they didn't back off any of the banter as well. I'd have been mortified if I was getting any special treatment.
Got worse.
And it's like an Oscar speech, but the Chewy Health team and the Physio Matters team that accounted for these things, these adjustments that I had to make. But yeah, I'm back all guns blazing now. So if you thought I was quiet last year, which very few people would think I was, but yeah, I'm back all guns blazing this year.
Excellent. Well, thank you so much. It's been a pleasure.
Thank you.
So there you have it. I hope that's not been too much of a self-indulgent episode. It wasn't the intention. I do assure you I had to be persuaded. I haven't twisted Paula's arm to interview me to put me front and centre, although I'm sure many would like to think that is the case. Hope you enjoyed that story, and I hope it's been of benefit. Certainly useful to understand things from as many angles as possible, and although I'm an atypical patient, we've got to try and bear in mind the people that we come to serve and the people that we try to help are in often complex social circumstances that's very individual. So the better you can get at eliciting their story, the better you're going to help them, or at least understand whether you're the right person to help them, understanding all the parameters and not narrowing them into certain compartments or categories. So hopefully there's a lot to learn. As I mentioned at the top of the show, we've got courses to give away from Neil Langridge with health education seminars. He's doing a course with Matt Lowe that I mentioned at the end of the last podcast, and they've kindly given a free space away, which is in venues across the country, and we'll be doing that on social media in the coming weeks. Also, Benoit Matthews, who is Function to Fitness at Function to Fitness on Twitter. He does courses on it's hip impingement courses and running rehabilitation courses, which are highly regarded, and he's kindly given a course space to our listeners. And what we're probably going to do with that one particularly is we're going to give patrons, we'll have 5 to 10 entries a piece into a prize draw, and then any followers on social media that retweet and share the draw,
then we will put an entry in for them as well. So it's not just for patrons, but certainly if you can join us on Patreon and support what we're doing, then please do, especially because the amount of content that we've got, exclusive content that's coming out to patrons in the next 6 months, probably 12 months, probably ongoing, but generally speaking, it's a real treat what we've got in store for patrons this year. So please do visit patreon.com and find the Physio Matters podcast on there. I'm at Choose Health on Twitter, at TPM Podcast. You find Paula at Paula Woods 5. That's her maiden name, don't get too confused. It's still Paula Deacon professionally. And you'll find us on Facebook and Instagram under the Physio Matters podcast. So enough from me. We've had a pretty Jack heavy episode. Apologies for that. You'll be delighted to hear that I will be speaking far less in our next few episodes, which are, as I mentioned at the top of the show, very, very varied in their content, but all super clinical, super relevant, and as current as they can be on some of the guidelines that we're going to be discussing. So lots to look forward to, and I'll see you next month. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.